Good afternoon. Assalamu alaikum, everyone. You all okay? We can start today's session. For start session, scientific session, advancing universal health coverage using microhealth insurance technology and medical registration. There are some interesting findings, results we would like to share with you. And definitely after that, we'll have a robust discussion. Before I commence, I would like to thank the Honorable Chair, Ms. Ellen Thorpe, Technical Officer at WHO Country Office, Pakistan. Our co-chair, Mohammad Ashar, Chief Executive Officer, Federal Science Program, Government of Pakistan. We are also expecting our discussants. Once they are here, we can introduce them. Uh, Originally, we planned to have 5 presentations today as per the schedule. But unfortunately, our presenter for DKT fell in and she left. So today we just have 4 presentations. So I believe we will wrap up before the scheduled time, maybe early for the lunch. So, with your permission, ma'am, should we start the session? Thank you. And the way we will do it this session, presentations will be done one by one, and kindly note down your question and answers. Because if you do a presentation and then you start Q&A, you will lag in time, and the other presenters will not get time. So every presentation, please note down any question you have. At the end of the day, if there is any question, you can raise hand and we can have a discussion. So first, let the presenter complete the presentation in the flow. Let him complete, and then at the end of all the presentations are complete, we'll have the Q&A session. And your chair and co-chair then will summarize and elaborate your feedback on the results. Thank you very much. We'll start our ceremony formally with the national anthem. You are all here to learn from each other uh, from the scientific session, the plenary. But we also must realize yesterday there was a very grave incident happening in Pakistan, where more than 20 soldiers have martyred. So we should also pray for their forgiveness, for the betterment for the family, and pray for the country that we are over with this going on scenario. So we must not forget these people who are protecting us. Thank you very much. So I'll start the today's session with first presentation. Okay. So we have now our first discussant, Dr. Adnan Khan. He is the Chief Information Knowledge Officer at Research and Development Solution. And Dr. Adnan will also be presenting this study. So the first study is by Microscope Society. And the title, it's a mixed method study, a longitudinal study of the assessment of youth application. And we'll share the findings of the youth application that was specifically designed for the youth in Pakistan, aged between 15 to 24. It talks about puberty, reproductive health, birth spacing, and so on. And I must acknowledge my co-authors from Mary Stokes, from British High Commission, and MSID choices. So, about some of the background about the youth and the SRH in Pakistan. So, we all know the new census is here. We are a population now almost 242 million. And in the last 5 years, we have added almost 4 million people in that cohort. And over 20% of the population is between 15 to 24. Uh, the low contraceptive prevalence rate since the last 15, 16 years, it's like plateaued. Uh, People face challenges, especially the youth face challenges to access SRH services, being kind of a marginalized and vulnerable population in Pakistan. The youth in Pakistan, we can see everybody has a cell phone, but that's more about the urban area. If you move on to the rural area or peri-urban area, you may find people having cell phone. But most of them are like people old analog technology. They don't have smartphones. So 87% of the household report owning a mobile phone with over 148 million subscribers in Pakistan. And that's the number of 51 million 3G, 4G. A high majority of the people are using smartphones between 10 to 30 years. But if you see the PDHS, less than 1% use a mobile phone for family planning. So there is availability, but the use is very good. Next slide. So the data from the low middle income countries, including Pakistan, is limited, supporting the ability and usefulness of such digital platforms for enhancing youth knowledge and modifying their attitudes and behavior. This level of smartphone penetration amongst Pakistan offers public health programmers a low cost and efficient method to reach the target population. Again, digital technologies, once you develop it, it's because uh, physically कहीं आना जाना नहीं होता आप मोबाइल पे एक्सेस कर सकते हैं. Next slide. Our study specifically aimed to develop and pilot test an application that provides efficient and evidence-based information on growth, puberty, reproductive health, birth spacing, with the support of the UK FCDO, the British High Commission, Pakistan, their flagship program, DAFPAC in Pakistan, which is delivering accelerated family planning in Pakistan. To increase the access to maternal child reproductive services of the environment. That's the aim of that. Our study's primary objective was to enhance access to knowledge and information related to RH, birth spacing, among the participants through a mobile application. I'll talk about the application later on, which may improve the intention and use of such services among the participants. So there were 3 phases of this study: pre-intervention, intervention, and post-intervention phase. Pre-intervention, there was a formative research, conceptualization, development of the communication material module, then designing the application. We designed the application first of all as a WPA, Progressive Word Web Application. But now that application has been transformed to Android and it's available to our customers. Then there was the intervention phase. We recruited youth studying in colleges and university in Karachi. And then followed them over a period of time. And then there was an N96 which had both qualitative and quantitative assessment. So, urban youth was the target audience. The application include modules on adolescence, puberty, menstrual health and hygiene, youth harassment, birth spacing, pregnancy, and general health. Study was conducted between 2019 and 2022, although we were supposed to end it early, but we all know in early 2020, COVID came, and there was complete lockdown for 6, 7 months. But now the participants were very there, so there was a slight delay in completing the study and the assessment. So the study population, both male and female, between we initially to have 15 to 24 years of youth, but when we tapped down schools and colleges, we did not get that acceptance because uh, uh, you need two things with the youth if they are not 18 years of age. One is assent by the parents, by the youth itself, and then the consent from the parents. So based on the topic and the sensitivity, we did not get them. So actual sample was between 18 to 24 years university students studying in college and universities in Karachi. Slide. These are the study phases. We did the pre-intervention between 2019, December 2019 and June 2020. Phase 2 was done between July 2020. I mentioned that there was that COVID issue. So June 2021, the intervention was completed, and then the post-intervention was done between 2021 and 2022. So we had focus group discussions before we designed the study, conceptualization, and after that, we again had for some focus group to know whatever we have designed, it's aligning with the central idea. Uh, and the end-line assessment, it has both quantitative and qualitative assessment. Next slide. And also there was routine monitoring. It was a regular follow-up with the youth through online surveys, SMS messages, and we also had that Google forms where we asked them to provide their feedback off and on. Once they started using that feedback on the content, the design, and how their perception perspective. So it was the longitudinal assessment where we captured their feedback over a period of time, not just at the point. Next slide. So all 137, because it's a longitudinal study, the number of participants who agreed, consented was 137. 58% female, the rest were like male. Single, not in a relationship, were 53%. Other than that, they were engaged, married, or they were single in a relationship. 73% lived as a nuclear family with the immediate family. The rest lived in the extended sort of family as a joint family. Next slide. 4 out of 5 participants were enrolled in undergraduate and graduate. So at the baseline, 82% of the participants had heard about puberty, information about puberty, and that increased to 95% at the end line. You can see from where they were getting that information. Next slide. The SRH knowledge was 43% at the baseline, and that increased 73% at the end. Next slide. Approximately 47% of the participants knew about birth spacing or a method of family planning at baseline, that increased to 62%. Maybe you must know that there's a difference between awareness and knowledge. People may be aware. Knowledge is different. Knowledge comes with when you apply it. You must be aware of something, but once you know about in detail, that is knowledge. More than 90% said youth application helped them to provide family planning information. Slide. We also talked about harassment, abuse. So at the baseline, only 79% knew what is actually harassment, sexual harassment, abuse, and that increased to 93% at the end. About family planning, birth spacing, knowledge, information, and access. The baseline, it was 78%, and by the end line, it was 8%. We asked them about have you ever heard about family planning method? And these questions were basically asked before this we started the study. Ever heard? Have you ever heard about any method? So they mentioned. So you can see that 78% have heard. Do you know of any family planning method, 85% said yes. And then if you find any information regarding family planning or birth spacing, it's better from the youth application, which you were not know about it, was 91.2%. We also had information on HIV, AIDS, and STIs. So 92% at the end line have heard about HIV and AIDS compared to 84%. 50% pregnancy were wanted at the baseline and end line survey because I have mentioned that we had a group of 18 to 54, so they were married people as well. So have you ever been pregnant? The response was 27.7% at the baseline and it was 29.9%. Thinking of most recent pregnancy, did you want to get pregnant at the time that it happened? That increased for 50 to 51% very marginalized. And what was the outcome of the pregnancy? Currently pregnant, almost 20% abortion. That people may have them responsible abortion. So that reduced from 18.5 to 13, almost 14%. It was like 4.5%, 4.6% reduction. Next slide. We also, as I mentioned, explored qualitative views from the respondents. So we had separate female and male respondents because the topic is sensitive. We cannot have same groups. We had female respondents and male respondents. So the respondents requested more tailored information based on the age and gender needs as the interests vary, such as stress management. They want to have more information. Stress management techniques, addressing issues related to SRH, learning more about pregnancy related. And these are the supporting questions. All the respondent exhibited keen interest in utilizing this online chat because the application has information and it also has a blog. Now on the Google, initially at that time it wasn't enabled. Now we have that people can chat. The application also have information about service delivery points nearest to them, and they can access it. They can access the toll-free number, call and get the information 8 hours per day. So all the respondents exhibited keen interest in utilizing online chat to post queries, access counseling services, and to have that location of nearby clinic, to have counseling session, to access any services to discuss, or any post follow discussion. However, barring one respondent not access counselor services. इस समय inline पे एक हमें मिला जिसने access किया था. So intention was there, but actually practically, because there is a reluctance. लोग जाते हैं थोड़ा सा परेशान होते हैं, घबराते हैं. That's why people mostly access the information on application. So there is a need to have specialized clinics and places where youth specific times, youth specific agenda, youth specific crisis होनी चाहिए. The youth pro services होनी चाहिए. Next slide. Despite the overwhelming satisfaction expressed by most of the users, they have suggestions on the improvement of the outlook, the cosmetic जो setting होता है कि जिसको थोड़ा design को change करें, colorful बनाएं. So people had that. And as I mentioned, the initial जो study थी that was completed on progressive web application. Now it's on Google Play Store. It's more aesthetically appealing. There was feedback on the language of the application. The recommendation also came incorporating content on Urdu and regional languages. Now there is content on Urdu language. We are working to have regional languages incorporated, but as these are donor-funded projects, you may find someone to find the translation. Respondents also voiced concerns regarding complex terminologies and concern because it is SEO to submit. So we've tried our best to explain them, define them within the application, but again, knowledge level from area to area education wise, this thing is valid. So we will inshallah work on it to improve further. Next slide. So conclusion, the study revealed that the trial of the new application increased the knowledge of reproductive health and has a potential for expansion. But again, at the same time, it's crucial to consider the feedback which we got, especially from young people during the qualitative exchanges. Usually slides में aesthetics, we have language, we have access की भी बातें हो रही. We have to incorporate them. So as youth-friendly encounter, copious amount of data for various resources are there. You can go on Google, you can get everything from videos to audios to narrative. It's not about the availability of information, it's about the availability of the correct, right information, locally contextualized information. Because most of the time that information is there, they will start with the right thing, but then they manipulate. So try to use reliable, up-to-date resources, especially which are contextualized to your local environment, the region, country. Otherwise, you may find yourself in trouble. Thank you. And for the next presentation, I request Dr. Adnan from Research and Development Solution. Thank you.
Thank you very much, Dr. Very still. And Sir, Purani and thank you everyone for being here. आप लोग मुझसे कौन से students? कुछ initiatives. आप में से कितना है? How many of you want to have a career in public health implementation? Okay, good. And how many would you like to have a career in public health research? To start, इस टॉक में मैं ये चाहूंगा कि आप लोग जिस पढ़ रहे हैं उसको रिलेट करें. Some things will relate and some things will not. Please ask questions at the end. What comes to you? The point of showing this presentation is to actually talk about addressing issues using evidence. Evidence in real time, but also evidence in the long term. So I'm going to get started. This is about family planning and population groups in Pakistan and what can be done about it. So I'm sure most of you know something about Pakistan. If Pakistan, India, Bangladesh, and Sri Lanka were roughly at the same point in 1970, in the last 50 years, they have grown about 2 to 2.5 times their population in 5 times. So how is that happening? Every other indicator will be consistent. Family planning use of the sector has actually what we saw, it was very low in the 50s and the 60s. It was about 66.4%. It's kind of stayed that way until well into the 80s. Lady Health Worker program came in 93. Next 10 years, we saw a huge jump to about 33%. And then we stayed pretty much there. That's been a problem. Fertility, come here, it's fallen down. The fall in fertility did not come because of family planning. What do you think it would have come from? Any thoughts?
Lifestyle change. Lifestyle change.
आवाज नहीं आ रही है सर.
Lifestyle.
Lifestyle में very specifically age of marriage. So आपकी age of marriage Pakistan, India, Bangladesh की 16 साल in the 80s. From 16, it has Pakistan, it's gone up to almost 21. It stayed about 17 in Bangladesh, as I was seeing, looking at yesterday. So that's pretty much been the difference, at least to my understanding. So what's to be done? Next. So this is a story of a project that started in about 2017-18. Research and Development Solutions, RADS, my organization, have been running an urban impact lab in Rohtasol, which is behind Pir Vidai. Most of you will know this. These are 4 UCs right behind Pir Vidai.
in Rawalpindi. Poor urban settlement, lived there for a long time. It has a population of about 280,000 people, with about 40,000 households, roughly about the same number of American reproductive age. How do we know that? We've actually listed it. Mixed population, Punjabi person mixed for the most part. Median household income just a hair above the national average, it's about 52,000 rupees per year. By the way, this has been published fairly recently, so if anybody is interested, please reach out. I can send you the link. Most men are employed with the global supplementary force women are unemployed, very consistent with the labor force participation survey in Pakistan. It's about 9%. Okay, so what we did was very simply, one of the ways that we measured is RANS on its own has been doing annual household surveys because we do interventions. Not all of them are funded for evaluation. The annual surveys actually help measure those numbers. So annual household survey just before the intervention was about to start, roughly showed fairly consistent population with Pakistan, average age of 30 to 31 for women. Family planning rates were about 33% at the baseline, mostly modern methods, but mostly. The outreach was basically, it was the entire intervention was very simple. We talked to local women who had previously not worked, would have liked to work for some income, please come on board. We'll pay you a little bit. You give 1 hour, you can give 2 hours, 3 hours, whatever you want to give. It doesn't matter. It's up to you. It's your choice. We also equipped them with a business in a box, a little bit of a starter with materials that they could sell. Supported them in some, stock, buying of stocks at wholesale, those kind of services. Supported the program with the data management. And funding of this program is from the government to CBIS program. Next week. So again, 36 women were identified. They were given basic training in outreach, in counseling, in some sales techniques, how to talk to people, those kind of things. They went house to house. They were given a very simple paper-based form initially, with one A4 page. The form was actually designed to be a checklist. It was from, is this woman married? Does she have kids? How many kids? Would you like to use family planning? Yes, no. If yes, would you like under the pills? Under the pills were there, like lady of workers do. If they wanted something other, there was a referral available. We had made arrangement both in the public sector and the private sector locally, and they were referred. Once they were referred, somebody followed up a week later and said, "How are you doing?" You started their U method last week. How are you doing? So about 2,500 rupees to about 300,000 rupees a month. They earned a little bit more by selling their business in a box supplies. There was one more male mobilizer for every 6 of about 6 or maybe 7 of them. In total, usually working in the evenings, trying to catch men as they come back and talk to them. Data collection, again, I described. Local some local private healthcare providers were also involved. There was a public sector PWD that was part of this. So as I mentioned, there was a baseline survey which showed a 33% prevalence of contraceptive use of contraceptive CPR, mostly condoms. 1,500 women were randomly surveyed, sampled for the survey. And in addition to the annual survey, we could calculated program data was tracked. So once the forms were turned in, supplies were given out, those were tracked, and that was put on a dashboard. Dashboard that allowed the teams to actually make some decisions on a weekly basis. That was granular enough that we could actually do for individual companies or outreach workers, but we could also do it for individual women in the house community. Using condoms, we could actually go back to the person and state and say, if you're comfortable with this, we can help you do it. Such as IUD or so what we saw in our annual survey at the beginning and the end, the difference was from 53, the CPR went up to 44%, 11% rise. The timing of the survey was not exactly consistent with the thing. It happened a little before the end. This intervention ran for about 14 months. The survey was actually done in about 11. So in 11 months, 11% rise in CPR. Some in condoms, there was a rise in injections. A lot of people who had started with injections shifted to getting them with us. And no one particular method stands out, but a lot of IUCDs were taken up. Almost 5,000 additional IUCDs were taken up during that period. Next week. Dashboards helped a lot. And this is where I would like the public health intervention people. That's why I was asking. So what was happening was that every week the team would sit down, the data team would sit down with them. We'd identify people who had started with pills, who are non-users, started with condoms pills. Now we could go back 2 months later or months later and say, here comes the would you like to do it? About a third to half of the people actually shifted to a better method. But there was ability to do that. There was also ability to actually say, this person started last week or 2 weeks ago, can we go back? Because remember, Pakistan discontinuation rates have been high, 30 to 38% in national surveys. Doing this, we could drop this discontinuation to about 17%. Because a lot of the discontinuation is based on fears, maybe some mild side effects that really don't warrant the message to be stopped. And those women would be allowed somebody to understand right there and then, just as they were starting to encounter the side effects. Hormonal effects, contraceptive will cause quite a bit of side effects. So that's always been a problem. This is with our way of addressing. Again, we could repeatedly go back to non-users, particularly young couples who probably could have benefited to them. The database allowed us to repeatedly use it. That on the right side in the bottom, you can see how the usage of methods went up. The drop is basically because everybody who was going to use started saturating with it. New IUCD they peaked around midway through the intervention. Less and less were given out every month because there were no people looking for IUCDs. And then had the intervention been longer, we would have been able to explore people that's have a little bit of get at the end of the thing. And you can see the dashboard up there. It's very good. Next. Average income was about 4,000. So 3,000 was the stipend, about 1,000. More the women could do with on average, but there were women that increased their income over 10,000 a month. There were few of them that increased over 7,000. These are women that had previously never worked. So again, there was a knock-on effect. Local women were saying, कि आपने बाजी को वो किया था, can you teach me how to do this? Well, so that program has actually into another entrepreneurship program that's good. Um, some people just don't understand. Some people don't understand. And we learned that not everybody has the same likes, dislikes, and skills. So we have to, that's one of the things that our big programs have to, what's the skill set of the people that you're doing. Next. There were issues. Puppies themselves came from that community. They were very hesitant to talk to young people. They were very hesitant to talk about ACDs. There were repeated sessions with them to clarify their perception. Low literacy does affect counseling, so it does both the client as well as the provider. There's the issue. We worked with 6 private providers who started working with us, but then the selling actually supplies. Then there was a donor funded program that goes through that gives free supplies to them and they start with. Unfortunately, that's a reality. Male mobilizers were not particularly effective. Men were very tired by the time they came home at 6 or 7 or 8 in the evening. They really didn't want to talk about planning. They were very interested in talking with us about economic how to reduce family income. But some of the conversations would be made, it wasn't a big success. I think this is one of the big things when we're talking about this with the government, as well as with the cost was at that time about 1,000 to 1,200 rupees per user per month. That came to about at that time about $10. Now that, and I'll show you what has been the follow-up of that program. This program actually ended in 2019. Next, please. The next step has been a follow-up again by PPIF and Punjab government. Now started about since January this year. Expanded to Taxila and Vijayanagar as well. Instead of 40,000 households, we're now aiming for 3,500 households. Sorry, 350,000 households. Right now, 60,000 additional households have been introduced to the program. Contraceptive rates have gone up by 8% so far the year. And the costs for us so far have been so again, about 1,200 rupees, which now unfortunately is about $2.50. So again, you have to compare these costs with the Lady Health Worker program, which costs roughly about 6,000 rupees per user per year, and PWD programs, which cost about 3,000 rupees per user per program. That's the point. Our aim is to find ways to scale it at the entire city level in Rawalpindi for the next 12 months and to Islamabad. This is not wealthy localities, but all the urban slum localities that we talked about. Urban slums account for about a third of Pakistan's population, about 50% of our all rural population in Pakistan. They've been just missed out in interventions in Pakistan, and I think this is one way of looking at it. What's also happening is we are actually tackling on from other resources, screening for nutrition, immunization, and NC detention and diabetes. I think I'll stop here. That is the paper, by the way, that came out with. Thank you.
Dr. Nam, we present presentation. I would like to invite the next presenter, Dr. Navadviya on research and design advice in Oxford. being here in the questions of the UL. I'm going to talk about important stakeholders of the society. And, they belong from the religious community, and we are always careful talking about them. Because they always remain and always having the potential to be a change in the society. And it's depend what kind of change we are expecting from them. So I'm going to talk about one of the operational research project of Marine Stroke Society. Uh, um, the way I am saying the operational research because we wanted to execute and provide the services as well and bring the some learning from that operational project and for the future scalability if it is going to provide the positive outcome. So this presentation is about the engaging Nikah registrar for the newly wed couple on family health, prioritizing of spacing and reproductive health, and it was the 12-month intervention. So when we were reading about reading the literature, we came across that this is something not new. We have already examples from the Muslim countries where the religious scholars were engaged with the government programs. We have seen that those countries were having a higher contraceptive prevalence rate. So this is something we have to learn from the already existing examples. Since we know that in the start of the family planning program in Pakistan, we always have the two term, "Bache Doi Ache," yeah, this is un-Islamic. No? So the religious people or the religious scholar can be engaged to break this kind of misconception or the stereotype attached to the birth spacing or the sexual and reproductive health. And interestingly, we have some particular type of culture. Now. So if you are coming from the different background, then you can have more understanding if you are using the gender lens or the social constructive perspective. The way we create narrative in our society is based on our social practices. No? So the taboos particularly are the newly married couple. They always have a challenging situation to talk about their future life, particularly with reference to the number of children or the birth is passing. So this is the social taboos which restrict newly-wed couple to get more information or to talk about these kind of topics. So what we can do in that particular situation? So we have learned, and there is a proven example. There is always counseling and the education, which can change the mind. But it's depend who is talking about what topics. And if it is coming from the religious scholar, then definitely it is being supported from the community. Historically, we had perceived that they are the challenge to change or to support this kind of narrative. So ultimately, based on this understanding, we have designed the intervention to engage the Nikah registrar. Most important person. So we were lucky and having their support with from the along with the collaboration from the government of Punjab in the community development department, and we had designed the intervention to examine. I'm sorry for getting the slides. So we are in the slide M. Thanks. So just I want to show that yeah, we were having this design the intervention to examine if we are going to work with the data registrar and if we are developing their capacity. And I am honored to have Mumtaz Askar. She gave the training to the religious scholar, and it's really difficult topic to talk about family planning and some ladies talking with the religious scholars, so it's always question, but later we had the follow-up and they really appreciated as well. So we were wanted to examine that intervention, that how it is working, and then assist the intervention design or model if it has a potential to be scalable, to go for the scalability or not. So right. So this intervention was based on the 12-month period. In the first phase, we just trained the
religious scholar, and then this was the inception phase. And then before this, we had developed the training manual. It was approved by the government of Punjab as well. And then we delivered the training, and then they trained 25 religious scholars, no, this registrar. So and allocated some particular number of nikah they're supposed to perform, and then about 600 we set the target that at the end of the intervention we will have the 600 newlywed male that they may get a counseling from the nikah registrar at the time of their marriage. So yeah, like and the data which I'm going to present in this presentation is based on the qualitative and quantitative side. And we had the follow-up mechanism apart from conducting the interviews at the end line through the telephonic interviews and then in-depth interview with the religious scholar. We were having a routine follow-up that once the registrar was giving the counseling and then filling a form, then this form was coming to the head office, and then we were having a direct contact details, then based on the consent, right? We are allowed to approach them. And then we were following up every like, month and then getting their some data and providing them some information as well, because we wanted to continue the process. Like, in the first slide of the results section, I want to share that mostly we were having a youth, since they were the newly married couple or the wed, they were having an age group from 21 to 30. Mostly were the employed. Again, it's our social practices. Until unless आपने कमाना शुरू किया आपकी शादी में. So 60% were the employed, other were working even liberal. So next slide. And mostly were this was interesting to note that mostly were like primary or the less in the primary. So this was something that we were having an intervention in the particular geographical areas where socio-economic situation was not very good, or mostly the working class was living. So, and in this slide, I will share two of the numbers. One is a 96% and other is a 76%. And the 96% was showing that we wanted to confirm that even if they got the counseling as well or not, so 96% of the respondents confirmed that at the time of their nikah, they received the information. And 76% of the respondents said that the information given to us was new about the family planning was new for them as well. In the next slide, I wanted to highlight that we also tried to cover if have they ever heard about the family planning or they were having the education. Here we have to distinguish between the information and the concept of education. Then we came to know that 33% of the respondents said yes, they were having some information about the family planning, but how to use, what is the suitable for them. It's something about the education. And then 17% only said that, yes, they have the education about the contraceptive method as well. So it means not only having the information is not enough. You have to know that how to convert this information into the education and what is the suitable method for them as. And further, I would like to share that 70% of the respondents said that just engagement of the nikah registrar is really useful to impact the attitude of the couple, or it can be a change agent. And more than 50% of express that culture and religious beliefs are a hurdle. Somehow our practices revolve around the based on our socialization, and this socialization always has the element from the culture and the religious practices. And fewer than the half still found it impressive to discuss contraceptive with the spouse after the nikah ceremony. But this is I'm talking about all of the respondents. Further, I have a couple of slides where I distinguish the respondent between the male and female as well. And you will see, if you use the gender lens, that the female is more open to discuss, and they don't perceive culture or the religion as a barrier as compared to male. And this is again our binary system, which put more pressure on the male throughout their life. and as compared to female before marriage, they are more having a pressure and more constructive practices which they have to follow. But after marriage situation changes, and particularly in this context of this research. Okay, so here shows that they were okay, like in both of the cases, either the wife is using the contraceptive or the husband is using 70 more than the 70%, but like in the support to use the contraceptive. And further, shares that since this study is focusing mainly on the knowledge, attitude, and practices, and you would be aware of the differences of this concept. So I'm not going into it. Just sharing that they got the knowledge that if they are practicing having a birth spacing, then it means the mother and child will have a better health. So they were having such kind of knowledge as well. And similarly, we wanted to assess the role of the Nigar registrar as well. And we came to know that more than the 84% was in the more than the 80% were in the favor that Nigar registrar involvement really helped to change the knowledge and impact the attitude and practices as well. So moving further, uh, what's the benefit of just giving the counseling and telling them, and then this counsel husband is talking with their wife. So we wanted to see the attitude and practices. And in this context, we came to know, and it's very like positive that at least 30% in couple intentionally delayed their uh, first childbirth based on this intervention. And secondly, 24% visited the health facility, but mostly they visited the private health facilities. So this was something different because they were always, we have the good network of the elective use, but still they prefer to visit the private health facility. And one third of this, and visiting the health facility are the deciding about the delaying the like a first birth. Then we came to know that this 65% of the decision was taken jointly, and one third of the decision was taken only from the male. So we were also positive with this result that at least they have the communication, talking with their wife and deciding mutually that what size of family they need to have and at what time they need to have the child. Uh, but like when, at the moment, 19% were using the contraceptive, but condom was the main contraceptive method. So it showed us that okay, they went on the family planning practices as well, but still it's a short term contraceptive method. That then and further research we have to explore how we can move them towards the long term contraceptive. Please. And here it comes to talk about the husband's wife, no? And it's still it's gender that it's against our honor. Somebody's talking about or questioning about their wives. So we asked if they may allow us, अगर वो हमें इजाजत दे तो हम उनकी wives and interview कर सकें. So only 25% of the respondents allow us to gather data from the wife. And the first question was that, okay, thank you so much. So did you speak with you about the family planning? So we came to know that 50% of 5% of the wives said yes, they spoke with us about family planning in the first specific. So again, this was the good side for us that at least because this was not, we were not involving the wives directly. We were depending on the husband that he may take the use of this counseling and may discuss with his wife. So this result shows that at least they will discuss. And when we were comparing the responses between the wives and husband, since we had the access to the information from the wives as well, so we came to know that women were less likely to consider religion and culture as a barrier to family planning. Earlier, I said that there was some certain because that time I was talking about the male response. But when we compared, then we came to know even under this take the burden as a religion and the culture is a barrier. here for the family planning. And comparing to their male spouses, very few, 4% consider in-law as a barrier to family planning. Even the previous studies was saying that the in-laws are really create the challenge, but situation is changing. Now. Dynamics are changing of our society. The challenge is the economic constraint and the quality of the concept of quality of life is really influencing somehow. They also consider that in-laws are not really barrier as compared to male. And compared to male, the female spouse, but less likely to agree that discussing FP with his spouse was impressive. So they were fine to discuss about the present with their husband. A large proportion, 48% of the female spouses wanted to continue the nikah registrar engagement for family counseling of their husband. So they were positive about it. So at this point, I will just use my presentation, but I will do the topics where I want to share the like a conclusion and suggestion. We can know this has potential because more than 38,000 of the legal registrar are existing in Punjab only. And they have really important role in our society. If something is message is coming from the some important institution of our society, and same time we have to impose or the institutionalize this from the structural means as well. With the support of government and government is asking for engagement of the Nigar registrar, then I am pretty sure that it can really influence the attitude, knowledge, attitude, and the practice of the male. And it's timely intervention because we have focused a lot on the female side for the family planning. And now we have to extensively work on the male attitude as well to be responsible their participating their family planning side, family planning practices to limit their family. Thank you so much.
Thank you very much, Dr. Agarwal. A very integrated so we now the last presentation. Also welcome our second key discussant, Dr. Babar Sheikh. So this was in the last scientific presentation session. A macro health issue to improve the maternal and reproductive health in those catchment areas. Next slide. It's a pre-post study. I'll come on to the design. So, maternal newborn child health indicators of Pakistan, we all know, are very drastic. And UNICEF reported Pakistan to be the riskiest country in the world to be born, and that's been documented. If you can go and web and search, with 1 in every 22 newborns dying within the first year of life. So that's very, very alarming, very critical. Moreover, Pakistan bears one of the highest risk of maternal death in the region of South Asia. Our indicators, national indicators, we all know about, very drastic. We have a population, 1/5 of the Pakistani population lives less than $1.25 per day, and over 60% living on less than $2.5 per day. Health services in Pakistan are typically financed through out-of-pocket expenditure. We all know the largest chunk is over 65% of the health is out of pocket, and a major proportion of that goes to the private sector. Next slide. Globally, microinsurance program has effectively produced improved economies and benefits the impoverished families. Microinsurance is characterized as an insurance program which operates through risk pooling, is financed through regular premiums, and is tailored to the poor who would otherwise not be able to pay. Our insurance, the normal insurance program, health insurance program, microinsurance program, from they are targeted on very specific population, marginalized, vulnerable, poor population. The premium is low, and they are especially designed for those people. Just a micro insurance loan, they will come low size of them. Easier to get them. Otherwise, health insurance for every other individual, you have to pay a high premium, and they don't offer everybody. You have to be employed by a company. Otherwise, you don't get health insurance services. Health micro insurance programs provide coverage to poor people for general health expenditure and provide potential cover the catastrophic health expenditures. These programs are aimed to producing similar key outcomes such as financial protection against the health expenditure and against healthcare utilization. Next slide. I won't go into details on about the insurance, but There are currently less than 10 million insurance policies in the market in Pakistan, of which 56% are life insurance, 39% are a combination of credit and health, and remaining mainly 5% are health micro insurance. And globally, we have seen that they produce some good results, reducing the catastrophic health expenditures. So the rationale and objective, we wanted to serve the marginalized community. This project was implemented by the support from the UK FCDO under the LAFPAC program to increase access to maternal, childhood, and reproductive health services of the marginalized population. And this present study evaluates the effectiveness of a microinsurance program to increase the maternal, child, and reproductive health services and enhance their financial protection. So what we did, we had a sample of 5,000 beneficiary families. 2,500 of the families were given free microinsurance, and the rest were asked to buy out of pocket. We are sharing with you the results of the free who took the free service, because only 5 policies were made out of pocket based on the locality where the study was implemented. Next slide. So it was a pre-post design for we use for the intervention targeting the marginalized population. We did the baseline somewhere around the start of the COVID. The actual sample size was around 2,000 plus, but we at the end line we only found 1,000 plus because there was people moved out, migrated, leave the area, so we not found the people actually. Again, and the target population was 15 to 49 years of married over reproductive age. Next slide. So education, if you see the education, the end line, the highest proportion had completed some of the education. The husbands, again, because it was in Karachi areas of the slums of the Karachi, but the husbands were at least have higher secondary level education completed. The number of being children, it was 2.7, the baseline, it increased to 2.3. The wealth status, because the areas which are selected, it has both low social and economic status as well as some middle income. So you can see there were almost 30% low wealth status, 13% middle, and rest fall in high status. Next slide. So the study was not able to impact directly on the maternal health indicators. You can see the skill and prenatal care utilization decreased from 71% to 50% at the end, because we had 3 major outcome indicators: maternal health, child health, and reproductive health. Again, place of recipient delivery, private sector share reduced at the end line, and public sector share increased. But at the same time, if you can see the antenatal visits, less than 8 visits, which were like 53% at the baseline, increased to 86% at the end line. So there was the families who came to the dedicated center where they get the health insurance support. Increase in the first 8 visits was significantly very high, and more than 50% came to the dedicated MSS facility for this health insurance plan. Next slide. Contraceptive use increased. It was any method from 38 to 53% at the end line. Any modern method increased from 30 to 47%, and there was a drop from 9 to 6% in traditional method. Almost 85% came to MSS clinic for seeking reproductive health services, including contraception or post-abortion care. Reproductive health services such as post-abortion care increased from 38% to almost 60%, with 94.8% respondent obtaining PAC services from MSS clinics in the vicinity. Next slide. Changes in the health seeking behavior. When was the last time any of your child received care from a healthcare provider? So you can see the results. MSS clinic was on the top, 26.6% went in MSS clinic. Public sector share also increased. I mentioned earlier, even for maternal health care, that share has increased in public sector. Maternity care, again, 3.8 to 13%, and they were mostly private clinics. Next slide. changes in the health seeking behavior of personal health. So they went to MSS clinic almost 25%, 20% for the public sector, and the rest private other clinics other than MSS. And that's the frequency less than 1 week ago, within the past 2 weeks. That was the frequency we wanted to capture. Slide. About satisfaction, majority of the respondents were very satisfied with the services provided. Next slide. And they wanted, and they see the insurance package was aligned with the demand. And we also asked perception about this specific micro insurance services to the respondents. Would you like to renew your insurance policies? So 97.5% said yes. And the people who said reason for not renewing or reviewing MSS policy, the response did not didn't use, so can't comment on it. It was 30%. The distance was the main reason, 50%. Then less work, 11.5%, and medicines are expensive, 3.8%. And the users, when we are the respondents, we like to recommend it to your friends and family. Over 86% said it's. Next. Average healthcare expenditure increased approximately from 15,000 to 22,000 PKR, while perceived difficulty accessing healthcare was reduced at the end. So there was an increase in the perceived expenditure. Perceived level of difficulty to pay for health costs, very difficult, 25.8%, somewhat difficult, or almost 60%. Next slide. So lastly, globally, these programs have shown positive impact of service utilization by mitigating monetary obstacles of the use. However, in our study, the uptake of the maternal health services, including ANC, we haven't seen that significant change. However, uptake of reproductive health services, birth spacing, family planning, and post-abortion care, we have seen a significant impact to this micro-insurance scheme. The beneficiary expressed high satisfaction and willingness to renew or recommend this insurance program to their peers, friends, and families. Well-designed pro-poor insurance schemes offer for a way to improve equitable provision of RS services. And as I said earlier, that all the 2,500 free and micro insurance policies were being distributed and they've been used. However, we are only able to sell out 5 policies. People only bought 5 policies. Based on the areas and geographies, we need to have more pro-poor insurance schemes. The way the social protection program is working in Pakistan, like Sahel program in the federal area in Punjab, in KTN and Rajasthan. So there is more need, especially to focus on the lowest quintile of the population, especially those who are business users, so they can get the financial protection and the rest can contribute as a program. Thank you very much. Thank you very much. Now we have completed our all 4 presentations. We have our key discussants, Dr. Imran Khan and Dr. Abhishek here. And we can now open the floor for 5 minutes for question and answers. Please, there were 4 presentations. I don't know if somebody have attended all of them. Answer question. Please.
मैं जानना चाहूंगा कि सर इसका स्टडी पीरियड क्या था और फॉलो अप हमने कब लिया, क्योंकि इसमें बहुत सारे ऐसे वेरिएबल्स हैं जो कि हमें परेशान करते हैं। फर्स्ट उन्होंने कहा कि हमारी सोसाइटी के अंदर टैबूज भी बहुत सारे, स्टिग्मा भी बहुत ज्यादा है कि हमने रिलीजियस पर्सन को इसमें इन्वॉल्व किया हुआ है, जो कि रिलीजियस पॉइंट ऑफ से, इस्लाम के पॉइंट ऑफ से लोग यही कहते हैं कि जिस पे बात भी नहीं होनी चाहिए, ये चीज़ एग्जिस्ट करती है। तो नंबर 1, नंबर 2, हमारे यहाँ स्ट्रेस फैक्टर होता है शादियों पे भी। बहुत सारे लोगों की लेट मैरिज होती है। फर्स्ट यही है कि मेल एंड फीमेल दोनों फर्स्ट नाइट पे उन्हें अपनी परफॉर्मेंस के हवाले से टेंशन होती है। क्यों? कि हमारे यहाँ इश्यूज हैं कि हमारे यहाँ जो वाल्स हैं, वाल चॉकिंग, बहुत सारे फैक्टर्स हैं जो कि हमें डिस्टर्ब करते हैं एज अ यंग, अगर मैं इसके ऊपर बात करना चाहूँ। फिर ये भी एक अगेन बहुत सारा फैक्टर ये भी है कि जैसे शादी होती है, 6 महीने गुजरते हैं, 8 महीने गुजरते हैं, इवन के जो मेल है उसका सास ससुर भी उससे पूछ रहा होता है, हाँ जी बच्चा हुआ है कि नहीं हुआ। ठीक है, अगेन ये टैबूज हमारी सोसाइटीज के अंदर है। तो क्या ऐसी स्ट्रेसफुल कंडीशंस के अंदर वो कपल जो है वो उस मैसेज को रिटेन भी कर पाता है, नहीं कर पाता, इस तरह के जो फैक्टर्स हैं ना, उसके हवाले से थोड़ा सा मुझे काइंडली इनलाइटन कीजिएगा। थैंक यू जी, थैंक यू।
हाँ सही पहले आ सकते बना लो। Thank you. Thank you.
Thank you so much for asking this such a beautiful question. You have asked a couple of things. Pehli thing social tables के हवाले से, दूसरी thing typical मतलब कि so called performance के हवाले से, और तीसरी चीज आपने कि इसको इस stressful situation के अंदर कैसे address करना चाहिए। तो पहला जो आपका था कि जो social tables है, ultimately if you are coming from social science side, then I would say ultimately हमें जब change लेके आने की जरूरत होती है, तो हमें अपनी normative practices या tables या so का जो constructive चीजें हैं, उन्हें मतलब sometime आप directly change करते हैं, आप sometime positive deviance के जरिए जाते हैं, और sometime आप middle way निकाल रहे होते हैं, ठीक है? Without changing those या deconstructing those tables, you cannot just overcome the hurdles or challenges, ना? So counseling, what it mean to counsel, ना? What it mean to educate, ना? इसका ultimate purpose यही होता है कि जो आपकी कल्चरल या नॉर्मेटिव प्रैक्टिसेस हैं जो कि किसी चीज को अचीव करने में चैलेंज क्रिएट कर रहे हैं, तो आप उसको पॉजिटिवली डोंट नीड टू डायरेक्टली गो इनटू द कॉन्फ्लिक्ट, बट उसको पॉजिटिवली आप चेंज करें, एक थिंग। और सेकंडली कि जी सो कॉल्ड परफॉर्मेंस, but this blessing doesn't mean to stop sex, no? We are not going to advocate for this, no? We are just saying the healthy family, no? We are just saying the communication between husband and wife, no? And in the very start of the first slide, I said that the countries where the religious scholars were engaged with the government interventions or the projects, they were having a higher contraceptive rate, ना? वो भी Muslim countries है, वहाँ पे भी cultural construction थे, वहाँ पे भी चीजें हैं, but you have to understand what is important, what is needed, ना? So I am not with the point of view or idea that it's totally un-Islamic, ना? Now we have the मतलब कि हमारे पास जो first training थी, उसमें मैम थी हमारे साथ, और हमारे साथ आए थे काउंसिल फॉर जिसको मैं ट्रम्प में थोड़ा सा शायद गलत कर रहा हूँ, जो काउंसिल इस्लामिक आइडियोलॉजिकल काउंसिल, तो उनके मुफ्ती साहब जो थे वो वहाँ पे हमारे साथ थे, तो हमने उनको सिस्टमैटिकली इंगेज किया। ऐसे ही नहीं है कि हम किसी को जाके मस्जिद में या किसी को लेके आ जाएं, तो दैट्स प्रॉपर प्रोसेस। So therefore we were having a positive results, and you have to have personal agency as well. When you are going with the counseling education, then there is a concept of the agency. If you are coming from the theoretical sides, and you have to have this agency when you are going to against the normative practice. I hope I have answered your question.
Thank you very much. Just wanted to respond. आप ही का सवाल था कितना काउंसलिंग के बाद there was a period of 12 months follow. ठीक है? So we have follow the group and the within our society for the Nikah registrar it's not possible to directly communicate these messages directly to the woman, female. So we use that catalyst. The groom was a catalyst. उसको counsel किया गया, उसको train किया गया. There was a training manual developed and approved by the government of Punjab. उसको training दी गई Nikah registrar, उसने फिर groom को दी, groom ने जाकर couple counsel किया, और फिर हमने groom को follow किया, फिर groom के consent से उसकी females को follow. देखिए पाकिस्तान में जब से फैमिली प्लानिंग प्रोग्राम आया है, रिलीजन इज नेवर बीन अ बैरियर। ये उठा लीजिए, पढ़ लीजिए, किसी फैमिली प्लानिंग ऑर्गेनाइजेशन के दफ्तर पे कोई ऐसा भाषा नहीं। इट्स ऑल अबाउट कल्चर, हाउ डू यू टैग ये टैग जो पढ़ें। तो हम व्हाट वी हैव सीन विद द स्टडी के 50% से ज्यादा कपल काउंसलिंग की होगी, कपल डिसीजन मेकिंग। और इन द आईज ऑफ द वुमेन आपने अगर आपने स्लाइड देखी होगी, यू मस्ट हैव सीन दैट women did not see religion and culture. It was coming from the male side because उसके laws उसके parents का था, माशरे का जो आप कह रहे सारे pressure वो। So how to counter this? So they practiced it, they used it, and we have seen significant results. Now we've been asked by the Punjab government to train all their 38,000 Nikah. So that is the change we are trying to do. Although we had all sex Nikah registrar, my first sex Nikah registrar सुनने लिए थे, everybody all supported. So there's a very positive change, and we need to invest in it because if you are not again मेरी बात है कि आप निकाह के टाइम में more than 80% जो sessions थे they happened at the time of निकाह ceremony. Few ने उसको कहा कि आप अभी थोड़ी सी बात करें फिर बाद में क्या करें, या मैं आपके पास अकेले आ जाऊँ, तो वो एक है, and it's normal. Not everybody is very open about it because it's a very sensitive problem. But again ये निकाह रजिस्ट्रार बेसिकली दे आर क्लेयरजीमैन जो आपके मजहब के मामले में होते हैं और दे आर मोस्टली डायरेक्टली कनेक्टेड विद द कम्युनिटी और सबसे ज्यादा जो हमने देखा है कि सबके सबको कम्युनिटी प्रैक्टिस कर तो इट्स ऑल अबाउट टेलिंग देम हाउ डू यू कम्युनिकेट एंड प्रमोट दैट मैसेज टू द पीपल सो दैट वी डिड इट एंड वी फाइंड सम गुड रिजल्ट एंड इट हैपेंड इन पंजाब इन लाहौर
थैंक यू सर, बहुत बेहतरीन आइडिया था सर। मेरा डॉक्टर कामरान सर, सर आपकी डिस्कशन से तो मेरा एक क्वेश्चन क्लियर हुआ कि इसका प्रोसेस किस टाइम तक, मतलब निकाह रजिस्ट्रार होता तो ये डिस्कशन किस टाइम कर रहा था, तो आप कहते हैं कि 80% ड्यूरिंग निकाह। ओके सर, और दूसरा सर ये कि वो काउंसलिंग के लिए क्या मैसेजेस वो निकाह रजिस्ट्रार दे रहे थे क्लाइंट, सर ये तो
इसमें हमने एक बुकलेट बनाई थी जो कि निकाह रजिस्ट्रार तो हमें ट्रेनिंग की ट्रेनिंग में के अलावा ग्रुप के लिए बुकलेट और वही बुकलेट you that you will pass on the same message to your when you get translated to the तो तमाम मैसेजेस डॉक्यूमेंटेड थे और वो उसके हवाले से it started with the family health, it started with the personal health okay? because in your marriage में क्या हमने कहा कि ये family तो we're not saying that to stop relationship, it's about effective workspace. Give time to think about it. Peer pressure बहुत ज़्यादा है, we all know about it. कुछ आदमी कि मुझे उसको पता होता है pressure. But it's all about giving time. ठीक है ना? Mothers are not machine. We also और तुमको proper time चाहिए और भी हमने देखा और आप DHS में भी देखें पिछले DHS से लास्ट DHS चले गए 2012 से लेके 2017 में डॉक्टर अलाम कपल काउंसलिंग बड़ी है हमारी उस पर वीजा भी आपके सामने Unfortunately, we don't see that impact on the CPR. But again, I don't know what we are missing in measuring that CPR, what's happening. But then again, couple of things happen. So there is a very strong potential. So we can use these people to pass on that message. Especially देखिए really bad के लिए बड़ा important है. अगर आप उनको timely deliver that message, the effective works basically. Any other questions I can even ask? Any question you want to ask? Okay, so we are on time. I would like to request Mr. Sir for his remarks for 5 minutes, so that then Aaron can summarize and we can do this. Thank you, sir.
Thank you, Dr. Puran. everybody. So सेट कार्ड के बारे में आप सब लोग भी जानते हैं, मुझे बताने की ज्यादा जरूरत नहीं है। फैमिली प्लानिंग, फैमिली को तो हम जानते भी हैं और मानते भी हैं। प्लानिंग के बारे में हमारी कौम जरा कम ही कायल है, नॉट द फैमिली प्लानिंग बट एवरी प्लानिंग। तो अब वक्त आ गया है कि हर चीज की प्लानिंग करनी चाहिए। सच्ची बात यह है कि आज जो दुनिया की सबसे बड़ी पॉपुलेशन चाइना, उन्होंने बर्थ कंट्रोल खत्म कर दिया है। आपको पता, बल्कि वो इनकरेज कर रहे हैं कि जी आप अगर आपको जरूरत है और सोसाइटी को जरूरत है, इकोनॉमी को जरूरत है, तो दुनिया के जितने बड़े इकोनॉमिस्ट हैं, आप पढ़ लीजिए लैटिन अमेरिका से लेके और यहाँ आपके साउथ तक, सब इस बात पे मुत्तफिक हैं कि वेल्थ प्लस पॉपुलेशन इज इक्वल टू ग्रोथ। अगर वेल्थ है, पॉपुलेशन नहीं है, ग्रोथ नहीं है। अगर एक दूसरी चीज नहीं है तो भी नहीं है। I was last week in Germany. I was having a conversation with the health minister in Germany. तो वो यही रोना रो रहे थे कि जी हमारा नेगेटिव पॉपुलेशन ग्रोथ, we don't have hands available as a workforce. हमारी 50% पॉपुलेशन 60 साल की उम्र से ज्यादा चली गई। तो ये इकोनॉमी कौन चलाएगा, ये फैक्ट्री कौन चलाएगा, ये इदारे कौन चलाएगा। उन्होंने ऑफर की पाकिस्तान सफीर भी हमारे साथ की इत्तेफाक से, मैं कहा जी स्ट्रेटेजिक एग्रीमेंट कर लें पाकिस्तान के पास, वी हैव इनफ पॉपुलेशन। सिर्फ आपको करना ये पड़ेगा कि आके उनको ट्रेन करना पड़ेगा अपनी कल्चरल और स्किल रिक्वायरमेंट के हिसाब से। एंड वी लव टू एक्सपोर्ट द ह्यूमन रिसोर्स, हमारे पास कभी नहीं। दिस इज अनदर एस्पेक्ट, द अदर साइड ऑफ द पिक्चर। पूरा यूरोप, पूरा नॉर्थ अमेरिका, पूरा ईस्ट एशिया डेवलप, ऑल नेगेटिव पॉपुलेशन, उनकी आबादी बढ़ने के बजाय कम हो रही है। 1.85 से नीचे जैसे ही आप जाते हैं आपकी पॉपुलेशन गिरना शुरू होती है। वन एस्पेक्ट। दूसरी एस्पेक्ट है कि वुमेन हो, मैन हो, अर्बन हो, रूरल, दे शुड मेक द चॉइस। आप ये जो टैबोज वगैरह हैं हमारी हकीकत है, हमारी सोसाइटी की, हम उसे आंख बंद नहीं कर सकते। बट दिस टैबोज अब आपको इंटरनेट ऑफ थिंग, इंटरनेट टेक्नोलॉजी ने उड़ा के रख दी। याद है पहले ये हमारी जो बच्चियां हैं, हमारी जो बहनें वगैरह जो बड़ी उम्र की थी,
तो हमारे जमाने में तो उनके पास किसी सहेली का फोन आता था तो अम्मा की फोन उठाती थी, कहती अच्छा क्यों बात करनी है आयशा से, क्या बात है बेटा, वो तो सो रही है, ऐसा कह रही है तो सुबह स्कूल में मिल लीजिएगा। अब तो नहीं है ये बात। अब तो बच्चा हो या बच्ची हो ब्लैंकेट के अंदर होता है, मोबाइल उसके पास होता है, आल वेरियस प्रो। ये तो नेगेटिव साइड वाला है, लेकिन पॉजिटिव साइड भी तो है कि बच्चा बच्ची जो है, दे कैन, मियाँ बीवी जो है जिनके पास बाकी वेरियस, दे कैन गेट एक्सेस। इनकी जो तालीमात हैं, उनकी जो कोशिशें हैं, हुकूमत पाकिस्तान जो कोशिश कर रही है, एक बात जरूरी है, डॉक्टर फरूक ने बड़ी अच्छी बात, इंफॉर्मेशन नॉलेज बहुत थोड़ी, एक लफ्ज आप गूगल में टाइप करें सब कुछ उबल के बाहर आए, व्हाट इज द राइट सोर्स, उसकी क्रेडिबिलिटी क्या है। आपने जो बड़ी ऐप अच्छी बनाई है करम साहब, मेरा ख्याल है कि वक्त आ गया है कि हुकूमत पाकिस्तान या सूबाई हुकूमत इस ऐप की ओनरशिप लेनी चाहिए, इसको मैनेज आप लोग करें, सारे इदारे पॉपुलेशन में एक आप ग्रुप बना के तो हुकूमत पाकिस्तान इंडोर्स करें कि जी ये पाकिस्तान फैमिली प्लानिंग है, कोई भी एक अच्छा सा नाम, एंड एवरीबॉडी नोज अंडर द ब्लू स्काई ये रिलायबल इंफॉर्मेशन, चाहे वो हेल्थ हो, चाहे वो हाइजीन हो, चाहे वो रिप्रोडक्टिव हो, रिलायबल इंफॉर्मेशन की बहुत सख्त जरूरत है। और एक और बात हमारी बाबा जी कहा करते थे अशफाक अहमद साहब, वो कहते थे कि जब हम रूहानी दुनिया में जब बैत करते हैं हाथ पे हाथ रख के पीर साहब और मुजीद साहब, तो लोग घबराते हैं कि बैत का मतलब होता है कि अपनी जान अपने मुर्शद के हवाले कर देना। बोला हेल्थ में तो लोग नहीं झिझकते, हमारे यहाँ झिझकते हैं। हेल्थ में क्या होता है, अगर मेरा या आपका कोई प्यारा खुदा ना खास्ता सर्जरी की या हॉस्पिटलाइजेशन की जरूरत पड़ जाए तो क्या करते हैं, मैं और आप अपने प्यारे को स्ट्रेचर पे डाल के ऑपरेशन थिएटर पे दरवाजे पे छोड़ के उस डॉक्टर साहब के हवाले कर देते, पूरा का पूरा हवाले कर देते। क्यों? ट्रस्ट। ये हेल्थ केयर प्रोफेशनल्स हैं, इनके बीच में और मरीज के बीच में या लवाहिकीन के बीच में ट्रस्ट होता है कि वो महफूज आते हैं। इसी तरह जो सेहत सहूलत प्रोग्राम जो है, जहाँ कोई 25 से 30 हज़ार एडमिशन रोजाना होते हैं और 1 लाख के करीब मर्द तो खवातीन रोजाना रिव्यू करते हैं, वहाँ जरूरत है कि उनको उस पैरामेडिक्स के जरिए, डॉक्टर साहिबा के जरिए, डॉक्टर साहब के जरिए तो बहुत यकीन करते हैं कि डॉक्टर साहब ने जो बात कर दी वो ठीक कर दी। इतना मजहब के मामले में माजल्ला देहाती मुआशरे के अंदर लोग मौलवी साहब को कोई पैगंबर से कम दर्जा ही देते नाउजुबिल्लाह। इस ट्रस्ट को पॉजिटिवली यूज करने की जरूरत, चाहे निकाह रजिस्ट्रार्स, चाहे आपके साथ रज़ाए कराम, चाहे आपके डॉक्टर साहिबान, इट शुड बी ए कलेक्टिव एफर्ट। इस तरह हमने यूनिवर्सल हेल्थ इंश्योरेंस का प्रोग्राम शुरू किया पाकिस्तान में, आज 20 करोड़ लोग इसमें कवर है, सिवाय सिंध के सूबे के तरफ ऑलरेडी कवर। अब हम सोच रहे हैं फ्यूचर में कि शायद यूनिवर्सल एजुकेशन प्रोग्राम भी शुरू कर, उससे कतई नजर एक आइडिया अभी वर्कआउट कर रहे हैं कि कोई भी कोर्स हो अंडर ग्रेजुएट या ग्रेजुएट, उसके अंदर एक नया इंट्रोड्यूस करवाएं सेमेस्टर, उसका सेमेस्टर का नाम हो फिनिशिंग सेमेस्टर। फिनिशिंग स्कूल होते हैं दुनिया में, पाकिस्तान में 3.5 फिनिशिंग स्कूल, जहाँ बच्चे को या बच्ची को जब वो तालीम लेके बाहर निकल रहा होता है उसे ये बताया जाए कि एक सेमेस्टर के अंदर 3 चीजें होती है। एक, आपको रिकैप दिया जाए कि पिछले 4 साल में पढ़ा आपने, इंजीनियरिंग, मेडिसिन, एग्रीकल्चर, जो भी पढ़ा, ताकि जो भी आप इंडस्ट्री में जाएं यू शुड हैव हैंड्स ऑन नॉलेज। दूसरा, हाउ टू हंट ए गुड जॉब। तीसरा, हाउ टू मैनेज ए फैमिली, फैमिली की रिक्वायरमेंट क्या होती है, मियाँ बीवी की एक्सपेक्टेशन क्या होती है, इंदाज को कैसे मैनेज करना होता है, सोसाइटी में कैसे जीना होता है, होम इकोनॉमिक्स कैसे मैनेज करनी होती है, मीडिया इंफॉर्मेशन शादी को कौन सी चीजें खराब करती हैं, कौन सी चीजें अच्छा करती हैं, ऑल दीज थिंग्स। इसके अंदर ये पोर्शन भी शामिल है रिप्रोडक्टिव का, ताकि वो बच्चा या बच्ची जो स्कूल से बाहर निकले उसे ही नॉलेज नहीं मिले, उसे किसी अनरिलायबल सोर्स, अपने साथी या इंटरनेट किसी स्टूपिड साइट, उस पर डिपेंड ना कर। ये भी बहुत जरूरी है। वी शुड डू एन आर्टिकुलेट, वेल ऑर्गेनाइज्ड एंड थॉट आउट, ताकि हर वो शख्स इस तरीके से भी फैमिली प्लानिंग करना चाहता है उसे ये हक भी हासिल हो, उसे ये एक्सेस भी हासिल, जस्ट इज डिपेंडिंग अपॉन। तो हम सेहत कार्ड प्रोग्राम के नीचे पायलट करने लगे हैं, रिप्रोडक्टिव हेल्थ का हमने किया है प्राइमरी हेल्थ केयर में WHO, and day before yesterday one dissemination ending report, inline report, बड़ी अच्छी रही। One more we are doing with the population concept, and I hope कि हम इसमें पॉजिटिव रोल अदा कर सकें। थैंक यू।
Saab, I will ask the chair to inform technical officer WHO and the Pakistan. Session.
Thank you. We've had a very rich discussion, a number of topics on youth, on community treatment, community planning, on religious leaders and their role, and also on health. Finance. In our session for the youth, we have seen that the youth is a unique group. They are neither children, they are also adults. There are a lot of complications that need innovative approaches to access, to allow that youth access health services. However, our youth in this country is not 100%, it's not a population that so we must ensure as much as possible that we provide access to youth services when it is needed. We have an advantage in terms of information technology these days. We have seen through this presentation that there was an app that was used. So this is a group that is very well versed in terms of how to use technology, IT equipment. If we can make sure that we target the youth through these methods, they can get the much needed information that they need, and we can increase their knowledge and they can make informed decisions. So we need to tap on this strength that is there, because eventually youth can be exposed to information that can be destructive, but if we are giving them the right information, then they can make the right decisions and the right choices. On the community-driven family planning, this was done in urban slums. Urban slums are usually heavily populated, and they are neither urban, neither rural. They are in between. But a lot of challenges also because of socioeconomic status of the population that live in slums. So they also need tailor-made services that they can access. In this study, we have blends. Our aim was to provide family planning counseling and eventually family planning access, but you can see that the package was much more. There was economic empowerment, which is a need to this type of thing. There was digital literacy, and also there was nutrition. You know, they have large families, they have poor socioeconomic status, difficult to feed the children, and nutrition also. So nutrition was handy also in this group. So we have learned through this study that through very economic ways, we saw the cost of the intervention. Very reasonable price. We can be able to increase the contraceptive prevalence rate as the results show, and we can be able to provide a package of not only health services, but also just social services that this group need. On the religious leaders, we have seen that they are key gatekeepers all over the world, but probably we are not using them to the effective level. We have seen how the religious leaders contributed to make sure that there's joint decision-making in families, which is very important. If you need to, the woman to use contraceptive methods, the man should know. Most of the time, we also neglect the men. But in this case, the men were involved, the religious leaders were also involved, and we have learned that the religious leaders are very key, not only to family planning, but most of the interventions that we advocate for. I have seen religious leaders also advocating for breastfeeding and many other food services. So it's a big lesson to us that we have this resource that we can tap and use for most of the health services, and we need to involve them in most of the because they are everywhere. They are regular, available, and are ready to support and get to involve them. Health financing, a very important issue. High mortality study targeted for events for basic emergency obstetric care. We have seen the contribution flashlight is the expert in that. So it's a technical message. We should have tailor-made insurance based on the population that we are dealing with to ensure that we reduce the spending and we avail of services to the types of population. Scale it. Lastly, I would like to thank the presenters. Thank you for the rich information that you shared with us. I would also like to thank the discussants and the chair, Mr. Ashad. The IT team, we didn't have any technical hinges. The session was flowed so smoothly. And thanks. Thank you so much. And lastly, let me thank the audience, very lively audience. A lot of questions came from the audience. And I hope that you have taken 1 or 2 messages that will help us as students and also as a public practitioners. Thank you so much.
Thank you, Ellen, for a very well summarized session. Before I ask Ellen to come to the stage and deliver the certificates to the organization, organizers, I must acknowledge one organization, Community City Advocate, the Islamic Majority Council of Pakistan. They helped us a lot in developing the manuals, reviewed the manuals, helped us to connect with the Punjab department. And I also must acknowledge Dr. Mumtaz as the senior technical advisor at Magistrates to help us to connect with this country. Thank you very much, ma'am, for your kind support, and we request you to be with us and continue your support. Ellen, can you please come and we can distribute the certificates to the organizer? Miss Ibra. Thank you, organizers, for organizing this event very well and help us to complete it in time. Miss Amara. And Sama. Because without this, when we are organizing the Miss Aisha. हाँ सबको लाना, engage करना, ensure करना कि हम family बैठे हैं. They've done an excellent job. Reach. Vikas. Sidra. Vikas. Karunika. Last, Miss Tavir. Thank you. Can I request the discussant, co-chair, please come for a group photo, sir? And the presenters, please. Ali. That's not correct, sir. नहीं, I'm running. ये group आ रहे हैं सब। पहले ठीक था, मैं आगे तो नहीं आया, नहीं आया। मस्जिद में समझे, वो भी group आ रहे हैं, हमने उसके group, बस ये है, फ्रंट आप ये